Hello, my name is Reverend Orresta Paddock, and I'm a Master's of Divinity student at Cherry Hill Seminary in the Department of Pastoral Counseling and Chaplaincy. And today I'm presenting on my proposed research for traditional Reconstructionistic culture and faith in modern end-of-life hospital care. The purpose of the study is to examine the satisfaction of cultural and religious minorities regarding the care that they receive while in end-of-life hospital care. We'll be making sure that we're looking at specific death and dying practices within these communities and making sure that they're being attended to by every facet of their care team. We want to look at whether they're being adequately attended to in a positive manner, not just by the spiritual care team, but by the whole care team in general. We're going to be using initial and exit interviews and focus studies in order to examine that. We'll talk about that a little bit more further in the presentation. And for the purposes of this study, we're defining satisfaction as recognizing and respecting the patient's cultural or religious views regarding the death and dying process. There is a significant lack of research within this topic. Most of the research that looks at cultural minorities focuses more on their other barriers to their care, as opposed to making sure that their needs for death and dying are met, such as financial income or language barriers. And most of the studies that look at religious minorities are still heavily Christian-centered, with just a few minorities tossed in to be equal, but not equitable. A literature review was performed at the beginning of this study in order to gain a better understanding of what is currently in the field and what subjects and samples need to be studied further. For the purpose of this study, we're defining spirituality based off of a study performed by Polchewski in 2014, which is dynamic and intrinsic aspect of humanity through which persons seek ultimate meaning, purpose, and transcendence and experience relationship to self, family, others, community, society, nature, and the significant or sacred. We chose this definition of spirituality because it doesn't focus just on the religious aspect of spirituality, but also on the cultural and community aspects that we find in a lot of minority cultures, such as Native American and Amish. For the purposes of this study, again, we're going to be using spirituality not just from a religious lens, but also the cultural lens that it can be viewed in. For the purposes of this study, we're going to be using a qualitative method of utilizing interviews and focus studies. Again, we're going to have an initial and an exit interview, as well as a direct care focus in between. The initial interview is comprised of 18 questions in total, 9 which are demographic questions, which help us to define the identity of the patients we're going to be looking at, and then 9 more detailed questions regarding their idea of spirituality, how spirituality affects them, what there are any kind of cultural, religious, death and dying practices that may be out of the norm. The direct care focus would come next. This would be about 10 hours of direct study, organically and naturally observing how every facet of their care team is able to attend to the specific needs of the patient, whether that is allowing them to pray at certain times, or if that is being respectful of skin-to-skin contact, depending on religious or gender identity. Again, this is not going to be just whenever the spiritual care team comes in, but we're going to be looking at also the nursing teams, any kind of immediate doctor or intern teams come to look at them. And then lastly, there will be an exit interview after the direct focus study, probably a couple days after, in order to gauge the patient's experience and allow them to further expand on how they feel their spiritual expression was attended to in a positive manner. We are aiming for about 10 patients. We ideally would like to have 5 that are cultural minorities and 5 that are religious minorities. That way we can get a better understanding of expressions and experiences across the different categories. We feel that this is a large enough group sample in order to get a wide enough variety of experiences, but it's also small enough to still be manageable given the resources we have. Our inclusion criteria for this study are those who have recently been in end-of-life hospital care. Recently, we're defining as within the last 5 years they've been given their prognosis. Those who are within New York State hospitals, anybody who resides outside of New York State is going to be excluded from this study. Looking at specifically New York because it has a lot of different cultural and religious minorities within the city as well as the state, looking at other different kinds of communities. And then they have to identify as either a cultural or a religious minority. They can identify as both, but they have to identify with at least one of those. And some examples of those are going to be Asian, African, Amish, Native American, and First Nations, or pagans. And our exclusion criteria are those who are within hospice care and nursing homes. Again, we're looking specifically at end-of-life hospital care and those with a terminal prognosis. Anybody outside of New York State, pediatric patients. For the purposes of this study, we're going to be looking at just adults. Pediatrics with spirituality can become a touchy topic when focusing on the consensuality of defining a religion or a spiritual practice to a child. So for the purposes of the study, we're going to be looking at just adults. Anybody who is diagnosed with a non-terminal disease, again, we're looking at specifically end-of-life prognosis care. And then anybody who identifies as white, non-Hispanic, Christian, Jewish, or Islamic, unless they also identify as a cultural or religious minority. So for example, we're not going to be looking at white Christian patients. There's been plenty of study within that field and how their care is attended to. And we're also not going to be looking at anybody who is not necessarily religious, but is a spiritual white person. So anybody who identifies as spiritual, non-religious. Again, we're going to be collecting this data through those initial and exit interviews. They're going to be able to gauge patient statement directly from their experience, and it's going to allow us to look for keywords which we use for analysis. And then those focus studies, which allow us to also more organically and kind of hands-off observe the care that they have. We would ideally and like to be more like fly on the wall kind of to the care, just kind of observing, no input, just making sure that what we understand from the patient based off that initial interview is actually being attended to. Again, we're going to be analyzing this data using key terms used by patients. So anything that is expressed and related across different patients. So phrases such as I was satisfied with the care that I received, or I feel like this practice was misunderstood. Anything like that that is going to give us a general experience across these minority cultures. And we're looking at trends that if they are in just cultural patients and within religious patients and the different experiences that both of them have. As I stated, there is a significant gap in this topic. A lot of the studies that have begun to go down this sort of field of study have determined that there is still a need for further cultural sensitivity study, especially within specific minorities. Like I mentioned as well, a lot of the studies that have focused on minorities, and especially minorities in New York, have looked at how their healthcare is affected based on their other statuses. For example, a study performed by Ross et al. In 2020 looked at the effects of COVID-19 on the immigrants in the Bronx. The Bronx is the least healthy of New York State's 62 counties, but is also one of the most ethnically diverse urban areas in the United States in general. Ross et al. Looked at what factors are leading to immigrants specifically struggling against the vaccine and against the healthcare and the pandemic in general. And they came to a conclusion that a lot of the immediate workforce that makes up front-facing jobs in the Bronx were filled by immigrant individuals, which caused them to be increasingly exposed to the pandemic. However, those other cultural concerns that we talked about in the beginning of the presentation, the financial barriers, language barriers, a fear of healthcare and deportation, were all limiting factors to them getting care. So it didn't necessarily look at their cultural experience, but more other causes for not being able to seek care. Like I mentioned, financial concerns are obviously a very high cause of avoiding healthcare for many cultural minorities, as a lot of them get put into entry-level base positions that don't pay well or don't have very good health care benefits. But also there comes language barriers when looking at cultural patients. There are a lot of words that don't translate properly into English from other cultures, especially in Asian languages, and specifically looking at the Filipino culture. They tend to translate a scale of pain on hot and cold versus high and low. So if a Filipino patient is experiencing high levels of pain, they may describe their symptoms as hot versus describing their pain as sharp or aching or unbearable. So this can obviously lead to miscommunications and misunderstandings in what the patient is actually experiencing. And then again, there's a lot of patients who have a fear of deportation due to specific forms or paperwork that they don't necessarily have with them, and the fear of being reported to an agency and then deported back to their country of origin. Ornstein et al. Looked at the differences between Black and white Americans and their healthcare, especially in the end-of-life hospital care. Again, one of the major reasons that they looked at this was based off of financial and racial bias, but not necessarily for those cultural implications. And that would be what I would be more interested in looking at in this study, especially when looking at Black patients and especially Black men and their cultural desire to kind of avoid negative emotions. Anything that seems depressive can sometimes be viewed as inappropriate in social situations within Black Americans. A lot of the current research in spiritual end-of-life care, again, focuses very heavily on Christian majority, with a few cultural minorities kind of sprinkled in just to create a level of equality, but not equity. This isn't entirely surprising, given that Christianity is the major religion of the United States. But what this does also mean is that there is room to focus on a more equitable research focused on these religious and cultural minorities, making sure that they are attended to just as well as their Christian counterparts. A study by Salman et al. In 2017 studied individuals from Catholicism, Protestant, other Christian, so any other denomination of Christianity, Muslim, Buddhist, Jewish, atheist or non-religious, spiritual non-religious, other religious, and no belief system identities. Only 2 of the patients of the study chose not to answer, but 2/3 of the patients were Christian, even though that only accounted for less than 1/3 of the listed faithful denominations that a patient could choose from. So 3 of the 11 religious denominations made up 2/3 of the study group. So again, it's heavily skewed towards Christianity and not necessarily looking at the minority faiths being represented. The results of that study did state that many patients felt as though their spiritual needs were not being attended to as accurately as they could be because of lack of resources and time from their actual care teams. There is, however, a Christian minority that I would be interested in looking at, which would be the Amish. There's a very heavy population of Amish citizens within New York, pardon. And they do have particular religious views on death. They choose oftentimes to die at home, and some avoid healthcare in general. There are those who do still choose to go to healthcare, and I would be interested in looking at the Amish community for this study, again, because of their important views on death, because if an Amish patient chooses to go to an emergency space in order to seek medical help, they are still deserving of adequate spiritual care during the time they're there. Challenges looking at Amish individuals would be that they, once they are given a prognosis, they tend to go home so that they can choose to die there. So being able to track them down for initial exit and direct focus study would be a little challenging. So all in all, what we can take away from this is that there is still a heavy need for research on cultural and religious minorities and how their spirituality is attended to in end-of-life care. This leaves room for further study, and a lot of the research that has already gone down this field has expressed that with more time and with more financial assistance, they feel they would be able to come to better terms and understandings. Thank you very much. Have a good rest of your day.